Hi friends, good evening. I'm Dr. Ashutosh Gupta and I'm a consultant in fetal medicine. So today we're going to talk about a test called as a quadruple marker, right? I don't know why it has gone into a disrepute, right? But as a clinician or as a fetal medicine specialist, this test has done wonders for me. And probably we are going to touch base upon this slide of this quadruple marker and probably try to look around the advantages of this particular test. This test had been introduced as a sort of a test to screen for Down syndromes, right? But the story for the Down syndrome is usually being done at 12 weeks. Whether you do this wonderful level one, in which we try to look around for all the markers, ultrasound markers for the fetus, and simultaneously do a double marker because then double marker has got an advantage of clubbing two independent parameters altogether. So the blood test from the mother and the nuchal translucency to the fetus, they can be clubbed, and therefore, or otherwise if the need would arise, we would do the NIPT and all those stuff. So meaning thereby that the story for the Down syndrome, whatever the risk might be and all those stuff, that gets cleared out by 12 weeks when we do the nuchal translucency. So why do we need this codal marker, right? So codal marker is a very good test. So as a fetal medicine specialist, I need to be technically right and clinically right. So I need to use this armamentarium or any test available into my arsenal very judiciously. So this would work wonders for anybody who would understand the nuances of this test. Now it has got four sort of markers, and therefore it is being called as a codal marker. So we know that whenever there is a abnormal analytes in all the four these hormones, then it becomes abnormal. So meaning thereby that anything which is greater than 2.5 moms or less than 0.5, 0.4 moms becomes abnormal. So we all know that my blood sugar, my blood pressure, my heart rate, if it increases for 95th centile for the gestational age, or whereas a human being becomes abnormal. So anything which is greater than 95th centile or less than 5th centile becomes abnormal. So 2.5 no, 2.5 moms is as good as 95th centile, and 0.4 moms is as good as 5th centile. Okay, so this is the baseline by which we really can see to it. Okay, so whenever we offer this codable marker, when we talk about the MSAFP, so this alpha fetoprotein levels, if they are higher than 2.5 moms, and therefore it would be indicated that it is in high risk for a neural tube defect, right? But with those advancements of the ultrasounds, there is hardly any possibility that probably and normal, usually the neural tube defect would not be picked up or would be missed at 12-week scan and would get picked up at 16 weeks, right? So meaning thereby that this caudal marker or MSAFP can try to look around for non-NTD reasons into the fetus, both in the fetus as well as in the placenta as well as in the mother. So let us run through these slides and then probably we'll talk about all these things in a greater detail. So as I've told you earlier, anything which is greater than 2.5 moms becomes abnormal, right? And then probably we try to look around the etiologies. So the non-neural tube defect, okay? So incorrect gestational age, multiple pregnancies, and there could be some maternal characteristics leading to this. So we can have an abdominal wall defects, we can have a kidney problems also, we can have a gastrointestinal, we can have a skin defects also, which is very, very important. And we can have fetal teratomas, as a matter of fact, and fetal anemias, evolving fetal anemias, which is being usually measured on ultrasound. We really cannot have an idea. And then very, very important is the feto-maternal connect. So we can have a preterm delivery, abruption, a PIH, preterm delivery, right? And therefore the preeclampsias, right? And fetal growth restrictions, FGR, and all those stuff, right? So this is very, very, this is a very abnormal phenomenon. So raised MSFP. So we can have a neural tube defect. We can have a non-neural tube defect. Okay. So a non-neural tube defect could be cleft lip palate, gastroschisis, omphalocele, evolving lesions, like we can have a sacrococcygeal teratoma which can be missed, which can be definitely type 4 varieties of an SCT, sacrococcygeal teratoma, they can be missed, and sort of an umbilical hernias, they can be missed, and some skin defects like we can have an aplasia cutis aplasia. We can have this epidermolysis bullosa or Herculean babies. Every now and often we see that the babies are being covered up in the fish scales. So this quadruple marker would pick them up, right? Anybody who is having an anti-thyroid drugs and therefore using a PTU and therefore we're having a cutis aplasia and therefore this would get raised up. If we are having a finished type of congenital nephropathy, any congenital nephropathy, nephrotic syndromes, the body, the fetal body would not be able to absorb this AFP and would get leaked out into the amniotic fluid and thus into the maternal blood and therefore that would be raised. Fetal anemia, meaning thereby that probably if we have not done any sort of an HPLC or thalassemia profile or could be any other hemoglobinopathy leading to severe fetal anemia, so MSAFP raised would be very very high. So this gives you the first indication. Secondly, we can have AV malformations. So we can have a vein of Galen malformations. We can have an choreo CCAM in the lungs. We can have an SCT. We can have a chorioangioma in the placenta. So all these lesions gets picked up. The chorioangioma would in the placenta would get picked up if it is greater than 5 centimeters. So before getting to 5 centimeters, it would be 1, 2, 3, 4, 5. So it would increase with increasing gestation. So probably increased MSAFP would raise our tentacles so as to see out of the box, right? And very very important is this growth restriction, so very high. So you complement this MSAFP with the dimer inhibin A, and if both of them are increased, so there is 8 times more likelihood to land up with a preeclampsia, a PIS to the mother, severe growth restrictions, absent end-diastolic flows, preterm deliveries. Even though we in twins also we've identified that if the MSAFE values are higher, so they are more chances of getting into a preterm delivery. So we should not see this MSAFP or a quadruple marker through the lens of the Down syndrome. Down syndrome, we have done away with this Down syndrome thing, and then probably we should increase our horizon so as to see furthermore. I wish to see the feto-maternal connect. So if it is a high risk pregnancy, every pregnancy is a high risk pregnancy. Nobody is a low risk, right? So I would be happy. So if the MSAP values are low, it would be high risk for the Down syndrome. That probably I've ruled it out earlier also by doing the NIPT. So the Down syndrome is out of my box. But if the MSAP values are low, I'm very happy, meaning thereby that I've ruled out non-entity reasons. We've ruled out all the sort of a nephroblastomas and SCTs to the fetus, teratomas to the fetus. I've ruled out AV malformations to the fetus. They would not be, and more importantly, is the feto-maternal connect. So I am very very sure that probably this baby would not end up with any growth restriction and doesn't need much surveillance. While on the other hand, if it is 3.5 moms of an MSAFP with 2.25 dimer inhibin A, I would be on my heels so as to see that we need to look around for the uterine arteries, put it on a low molecular weight heparin or an equaspirin and increase surveillance so as to see for growth restriction, and therefore there are a lot of things across to be done. So my point is this and take home message is this, that we should use the technology to its advantage. So earlier it was introduced for the screening for the Down syndrome, but the Down syndrome is out of my window because then probably I will not talk about the Down syndrome at 17-18 weeks. I'll talk about something more at 17. Down syndrome has been done away at 12 weeks only. And I would talk about the fetal connect. I will talk about the growth. I will talk about how the baby is going to behave as we, or the pregnancy would behave or would grow as we move on further, right? And if she is a previous section and the placenta is anterior, I would be more worried about the placenta, abnormal placental invasion. So if the MSAFE values are normal, I'm happy that probably I'm not dealing with abnormal invasions, whether it is a increta, pergreta, or accreta, right? But on the other hand, if the MSAP values are high, I would need to do an MR so as to identify the abnormal placental invasion into the myometrium, and therefore all these things would come into my fort, right? Okay, so probably they will come into my differential diagnosis. What would be the reason for this increased MSAFP, right? So every technology has to be used judiciously and cautiously to our own advantage. So we are clinicians, we are not technicians. So I need to be both technically and clinically right, so that I am reassured, and therefore I will pass on this reassurance to the couple that there is hardly anything to get worried of. If it is high, abnormal, then probably I'll make them that probably. we might need to do some more things, surveillance and low molecular repair and an equal space to the baby. Right? Thank you very much for your patient listening.